Symptoms of multiple sclerosis are both multiple and relate to the other part of the name, which is sclerosis or scar. In terms of multiple sclerosis means that a person experiences relapses or attacks that can affect vision, the optic nerve, can affect the brain, which can lead to balance impairment, coordination difficulties, sometimes confusion, or can affect the spinal cord, where people might have numbness, weakness, or bladder difficulty. The sclerosis component, or the scarring, means that there are areas of inflammation, attack of the immune system, in the optic nerve, brain, or spine, and that these areas are both symptomatic, in other words, they cause the symptoms I just described, or they can be in areas that don't lead to a direct symptom, but are causing ongoing injury in the nervous system, and that's the scarring component. So multiple sclerosis is both an inflammatory disease and a degenerative condition. And by that I mean that you can have inflammation attacks and difficulties that come and go, and then progressive difficulty if the brain injury were not to be treated or reduced. Multiple sclerosis is rare in children, so to put it in context, in this country, in the United States, multiple sclerosis affects between 1 in 800 and 1 in 1,000 persons, of whom approximately 5% have their first event prior to age 18. So there is no single cause of multiple sclerosis. Multiple sclerosis is what's referred to as a multifactorial disease, and some of the factors that have been implicated as contributing to multiple sclerosis risk include genetics. There is no single gene. This is not an inheritable condition where someone in your family passes a gene that their child inherits and then has the same condition. But multiple sclerosis does run in families in that if you have a parent with multiple sclerosis, your risk of having multiple sclerosis if you're a girl is about 5% in your lifetime. 3% if you're a boy, because women are more likely to have multiple sclerosis than men. So that means, and the other way around, if you have a parent with multiple sclerosis, 95 to 97% of the time, you will not have multiple sclerosis. If you have an identical twin, 30% of the time, both twins will develop multiple sclerosis in their lifetime. 70% of the time, one twin has multiple sclerosis and the other twin does not. So therefore, there are genetic contributions, but they do not define the sole risk for this condition. In our environment, things that have been implicated as contributing to multiple sclerosis risk most strongly would be Epstein-Barr virus infection, or EBV, the virus that is typically associated with the most common form of mononucleosis. However, most people in our society do indeed acquire this infection in their lifetime and do not have multiple sclerosis. So acquiring EBV as a common community infection does not mean you're going to develop multiple sclerosis. But people with multiple sclerosis are more likely, on average, to have been exposed to this infection than their neighbors. Children with multiple sclerosis are considerably more likely. In fact, 97% of children and 97% of adults with multiple sclerosis have evidence of an Epstein-Barr virus infection. But when you compare a child with multiple sclerosis to the same age-matched community, only about 40% of children at the same age in a general community population have had Epstein-Barr virus infection at that age. So that does strongly indicate that your likelihood of multiple sclerosis is associated with having been exposed to this virus, but it in no way tells us what the virus is doing that might contribute to MS risk. And it is not thought that multiple sclerosis is an actually infectious disease. It's more considered that this virus may trigger some part of our immune response that leads to a multiple sclerosis story. Quickly, other things that have been linked to a higher rate of multiple sclerosis include low vitamin D levels, a high body mass index, exposure to cigarette smoke directly in adults or secondhand smoke in children. And then there are a variety of much rarer associations. But The top ones are viral infection with EBV, a larger body mass index, low vitamin D, and lower risk, but still important, cigarette smoke exposure. Multiple sclerosis is a clinical diagnosis that is supported by MRI features and by laboratory features. On the MRI scan, we can look again back at that idea of sclerosis or areas of inflammation and scarring, and the pattern of those areas of abnormality can contribute to our certainty that someone has multiple sclerosis. So we have criteria that define the description on MRI of where these abnormalities are in the brain, optic nerve or spine, and what they look like that are very helpful in identifying someone with multiple sclerosis. We also have laboratory testing, particularly spinal fluid, which bathes the brain and the spinal cord, that is obtained from lumbar puncture or spinal tap. And in the spinal fluid, we have something called oligoclonal bands, which are proteins being made in the brain and thereby being secreted into this fluid that are an immune signature that is extremely common in multiple sclerosis and very rare in other conditions. None of those are specific. There's no one test that I can do with absolute certainty that would tell me this person has multiple sclerosis. We have to put it all together and use the diagnostic criteria in a careful manner. Well, multiple sclerosis is a chronic, lifelong disease, whereas ADEM, or acute disseminated encephalomyelitis, is typically a single acute syndrome, not a specific disease, that presents in a very characteristic way. The characteristic presentation of ADEM, by definition, is that someone presents with confusion or encephalopathy, altered awareness of their environment, which can progress to coma, often also with weakness, balance problems, bladder issues, visual loss. Fortunately, despite that severe presentation, most children and adults with ADEM will respond quickly to the acute therapies that we give, which include corticosteroids and sometimes other treatments such as plasma exchange or immune globulin, and can very quickly and quite frequently return back to their normal function. Multiple sclerosis, on the other hand, we treat the acute first presentation, which very, very rarely looks like ADEM. Most of the time it looks differently. The difference is that in multiple sclerosis, we know it's a chronic diagnosis, and that if we don't provide therapy long term, the next event, the next attack is going to occur. In ADEM, typically, we do not have a follow-up attack, and there are some new findings with ADEM. So about 50% of children with an ADEM attack will have MOG, myelin oligodendrocyte glycoprotein, antibodies, which are proteins that are attacking the MOG in the brain, the MOG protein in the brain. The children with ADEM with MOG antibodies are a little bit more likely to have attacks, and we use the word MOGAD, myelin oligodendrocyte glycoprotein antibody-associated disease, or MOGAD, to describe the children whose first MOGAD attack meets the criteria for the syndrome we call ADEM. 50% of children with ADEM do not have MOG antibodies. Their immune system is not attacking that protein specifically, and we just call them ADEM. For multiple sclerosis, there are now, in adults, over 20 approved therapies to prevent ongoing relapses, to reduce the likelihood of future disability, and potentially we hope, improve long-term prognosis in every way in terms of function, overall wellness, and health. Many of these therapies have the potential to be valuable in pediatric multiple sclerosis patients, but as is often the case, children are not involved or not included in the treatment trials that gain approval for these therapies. So of all the treatments available in the adult multiple sclerosis world, we have approval for one therapy in the United States, an oral medication that is a sphingosine 1-phosphate inhibitor, referred to as fingolimod. In Europe, fingolimod and a different therapy referred to as teriflunomide are approved. But many children with multiple sclerosis are managed currently using what we call off-label, or treatments approved for adults but not yet approved for children. And those therapies include medications called anti-CD20 therapy, of which there are 5 or 6 different medications in that family of treatments. Pretty commonly, those would be the most common group of medications that we use now. And then there are several others. But I think the message I would give is there are multiple treatments that work on reducing attacks. They all work a little differently, and they have different ways of being provided, whether that's infusions a few times a year, treatments more frequently than that, or the older treatments that were available, which included injections given every few days or once per week. In our clinic here at Johns Hopkins, we provide clinical expertise. Dr. Chen and myself in particular are the 2 pediatric neurologists that run the program. We are both specifically trained in pediatric neuroimmune conditions. We look after children with multiple sclerosis, MOGAD, and related conditions as our primary area of clinical expertise. From my end, I have been involved in looking after children with multiple sclerosis since 1999, and I have been involved regionally, nationally, and internationally in defining multiple sclerosis in children, in understanding multiple sclerosis in multiple ways in children, and in serving on the different treatment trials that have helped us bring treatments to children. Both Dr. Chen and I are involved actively in research that will help us even better understand multiple sclerosis, and most importantly, how to better treat our patients and to make sure that they live with multiple sclerosis in the healthiest way possible. The care team for a person with multiple sclerosis, whether a child or an adult, starts, of course, with their family and support team at home and partners with their healthcare team. The healthcare team here at Johns Hopkins includes a neuroimmune expert. So in the pediatric space, that's Dr. Chen and myself. In the adult space, we have several nationally recognized multiple sclerosis experts. We partner with nursing, and we have actually International Order of MS certified nurses who are very much experts in the nursing care needs of a person living with multiple sclerosis. If needed, we have partnerships with physical and occupational therapy. Happily, in our pediatric patients, they recover pretty well from their relapses pretty quickly, and we have rehab support, and we try really hard not to need it in the sense that our goal is to reduce relapses in the first place. But we have a wonderful support team when they're needed. We work very importantly with social work because living with a chronic diagnosis has implications for other aspects of our lives, and we want our pediatric patients in particular to make sure that if they need any help at school or any adjustments, because multiple sclerosis can make you more tired, that we make sure their school experience goes well. And we also want to support families that have more visits and may have financial needs to get to clinic and receive care. Psychology is pivotal. We offer neuropsychology testing to our children and teenagers living with multiple sclerosis who may have specific educational needs that we can identify, create an individual teaching plan for, and maximize their experience in public school, well, not just public school, any school, and subsequent secondary education. And then also we have psychiatry to help with the fact that about 1/3 of all persons living with multiple sclerosis will experience some episode of depression. And we want to be right on top of that so that we can make sure we're taking care of our whole patient and addressing all of their care needs.